was saying I was originally going to give this talk back in July, but I got sick and so I couldn't do it. And so I'm giving a shorter version today. And then I got sick again this week. I'm still doing it, but my voice is a little weak. So I'll try to speak as loudly as I can, but forgive me if my voice is a little muffled. Um, so today we're going to talk about treatment of substance use disorder in patients with TBI. So we can go and go to the next slide. So our learning objectives. So we'll spend just a few minutes going over the basics of traumatic brain injury. We'll discuss the bi-directional relationship between TBI and SUD. Sorry about the typo. The autocorrect didn't like bidirectional, apparently. We'll review the screening recommendations for TBI and substance use disorder patients. And then we'll review what accommodations are recommended in this patient population, and also, if this changes how we treat these patients. So next slide.
Sorry, Derek. I just realized that I had the not the final one that you just sent me up. So I'm gonna switch it really quick.
Oh, okay. Well, the next thing I was just going to say is, just yeah. So why are we talking about TBI? So here we are. We're in a panel on substance use disorders for counseling techniques for substance use disorders. So why are we talking about TBI? So if you want to go to the next slide. It's because TBI is very common. So we have some data from 2021 that says there were about 3 million traumatic brain injuries that year. And this is almost certainly an underestimate. And so this only counts people who went into some outpatient treatment, or either hospitalized or went into outpatient treatment. And so if somebody, didn't go into care, which is very, very common, especially in our patient population, or if they only went into the emergency room and then didn't seek follow-up care, then they are not included in these numbers. And so it may be double this. We just really don't know. But what we do know is that there is this connection between traumatic brain injury and substance use disorder. And so substance use disorders are very common in patients who have had a TBI in the past. And the numbers are again not conclusive because this is an area that's really hard to study. Uh, but we think that maybe 50% to 60% of people who have had a history of a TBI at some point in their life also have a co-occurring substance use disorder. Now, when we say they've had a TBI at some point in their life, this can mean anything from a concussion to a severe traumatic brain injury. So it is a pretty broad spectrum. Um, and then it also goes the other way. So patients who have a substance use disorder at a much higher risk of developing a traumatic brain injury from things like, falls, high risk activities, and then other kinds of brain injuries, for things like anoxic brain injuries from overdose and those sorts of things. Um, and then about a quarter of the patients with a substance use disorder who then have a TBI will have a moderate to severe TBI, which usually leads to more significant and lasting neurologic deficits, which make treatment harder. Go to the next slide. So this is another one of the many silent epidemics that we talk about in medicine nowadays. But I think it's fair because TBI is often under-recognized. This is the kind of thing that the symptoms can be quite subtle, and so if we don't ask for it or ask about it specifically, it's largely missed. Um, and then having a history of a TBI is associated with worse outcomes in substance use disorders as well as worse treatment outcomes. And so we know that it's associated with heavier substance use, riskier behavior, less treatment retention, and just generally less success in treatment if it's not addressed appropriately. And so it is important to think about really for anyone who works in the substance use disorder field, because it's something that we should be thinking about and screening for. Um, you know, this was something that so I started thinking about this more in the last year when I was asked to give this talk. Um, and I realized that I had not been, screening everybody for TBI. Fortunately, since I do work at the VA is very good about that. Um, but it was something that I wasn't aware that the recommendation is that really everybody should get screened. And we'll talk about that a little bit more. So I am a little curious if everybody has been screened. We don't have to show hands or anything, but I'm just curious if other people have been screening for TBIs and other patients. But we can go to the next slide. All right, so we'll have a little bit of a traumatic brain injury 101. We'll keep this, pretty or marginally superficial. I'm not a neurologist. I don't think anybody else here is a neurologist. If you're a neuropsychologist, you'll probably be bored. But we can go to the next slide. So what is a traumatic brain injury? So in short, it's any direct force to the brain that causes dysfunction. And so, that can be kind of the classic blow to the head, like you slip and fall, you have direct trauma to the head. It can be something that's just a hard jolt to your body, and then those forces are transmitted to your central nervous system. So I think for anybody who skis, you can have a concussion if you don't see it coming and you go over a little a rise and you land hard on a cat track or something. So if anyone's ever done that, you kind of feel that through your body. So if you have a particularly hard hit, you can get concussion or brain injury from that. And then also concussive blasts, and so we see that commonly in military populations from being around artillery and those sorts of things. And so, in order to be diagnosed with a traumatic brain injury, in essence, there has to have been some kind of mechanism that could cause it. And then there has to be at least one symptom that would be, loss of consciousness. It could be post-traumatic amnesia. You could have a focal neurologic deficit. There could be confusion, or you could have something seen on imaging, which usually is associated with more moderate to severe TBI. But it is possible that somebody could have pretty mild symptoms and, a concussion, and then you get a CT scan and they actually have a hemorrhage or contusion, which of course is a worse prognostic factor. We can go to the next slide. I'm trying to be mindful of the time. I tend to talk a lot. Um, So how do we classify a TBI? So unfortunately, it is a pretty crude system in a way. And so traditionally, traumatic brain injuries have been classified by the most severe symptoms, um, we'll say at presentation. So kind of the peak of the symptoms when the insult occurred. And usually that's based off of the Glasgow Coma Scale. Um, which is a scale that, lowest score is 3. But if you have a 13 to 15, that's considered to be a mild TBI or concussion. And then if you're 9 to 12, it's moderate. And if you're 8 or below, it's severe. But this only tells us about the symptoms that you had in that moment. It doesn't tell us about any kind of lasting deficits or really anything else about what's going on. And so some investigators have been trying to make more nuanced systems. So one that's I think recent last couple of years is the CBI-M framework. And so it has a clinical component, which is the Glasgow Coma Score, your pupil reactivity, any loss of consciousness, any neurologic symptoms. So it's kind of like a more complete picture. Whether or not there was anything abnormal seen on imaging, a hemorrhage or a non-hemorrhagic lesion, a mass lesion. Biomarkers, so they can actually draw your blood and then see if you have markers floating around that would indicate that you've had a CNS injury. And then the modifiers are your kind of classic biopsychosocial factors that would kind of complicate the course. And then in the bottom right, that's kind of if you're curious, the other ways you can kind of tease out how you might stratify a TBI based on things like how long did you lose consciousness, how long did you have amnesia, and those sorts of things. Then we go to the next slide. So obviously, TBI exists on a continuum, and the vast majority are going to be a mild TBI or a concussion, we might say. So that'd be about 80% of patients. And then the other 20 would be moderate to severe. Um, but we don't want to assume that because somebody has a mild TBI, that is insignificant, because that's not always the case. And so if we think back about how we classify the TBI, so Glasgow Coma Score of 13 to 15, um, some researchers will say, yeah, but if you have a GCS of 13 at presentation, even though we classify that as mild, it kind of behaves prognostically like moderate. And then there is this phenomena of uncomplicated versus complicated, meaning an uncomplicated mild TBI is, clinical presentation that fits the picture with normal imaging. Whereas complicated would be that same clinical presentation, but you do see an abnormality on imaging. So you do see, a contusion or a hemorrhage or a mass effect. And of course, that is even though somebody presents with mild symptoms, much worse prognosis. Um, so we don't want to assume if somebody says, "Oh yeah, I had a concussion once," that means that they couldn't have any kind of residual deficits because we just don't know by that alone. Okay, next slide. All right, so this is a bit of a busy slide. I had a few more going on to explain the behavioral changes with TBI, but I had to cut some things out to go from 45 minutes to 25 minutes. So in essence, what this is showing is that the behavioral changes that are associated with a traumatic brain injury are due to a number of systems that can be damaged. And so, most commonly we think about frontal lobe damage. And that's going to impact, executive function, kind of top-down control. Um, then there can be like a diffuse axonal injury, which is going to impede the connectivity of different brain regions, which can lead to more, reactivity, and less executive control. Um, and and then there can be, damage to deep structures and damage to the various neurotransmitter symptoms. And so this can cause what we, typically see in patients that have substance use disorders, uh, but amplified with traumatic brain injury. So we're going to see more impulsivity, we're going to see less stress tolerance, and all the things that will impact treatment. Go to the next slide. All right, so now we're going to get into substance use disorders and TBI. So you can go ahead and go to the next one. So I touched upon this briefly before, but how common are traumatic brain injuries in patients with substance use disorders? Again, the literature is kind of all over the place, but it's somewhere between about 50 and 80% of patients. Patients that have opioid use disorder, about half have a traumatic brain injury, or have had a traumatic brain injury, and about half of those had the TBI prior to starting to use opioids. There's also a strong relationship with alcohol use disorder. Um, and with alcohol use disorder, the literature is a little bit more robust, and it's been noted that it can be masked because when somebody has active alcohol use disorder, oftentimes the cognitive impairment is just kind of attributed to the alcohol use disorder. But then once somebody becomes absent, in about 30 to 40% of cases, at least a mild cognitive deficit is noted. Um, Now, is that from TBI alone, or is it also from direct toxicity of alcohol to the CNS? It's probably both. And then we have less data for other substances. We do know that patients who have stimulant use disorder who do suffer a traumatic brain injury tend to suffer a more severe injury. They tend to wind up in the ICU and have more significant deficits. But for cannabis and many other substances, we don't have as good a data. Go to the next slide. Okay, and so then the corollary, so TBI is also a risk factor for substance use disorders. And so we know that directly after a traumatic brain injury, there seems to be a decreased incidence of substance use disorder. And so if somebody had a pre-existing substance use disorder, they have a TBI, then there's often a period where the use declines. But then after, that period passes, usually that, they do return to use and their use becomes more severe. Or if they have never used a substance before, they are at increased risk. And the data goes out at least a decade, but it probably persists indefinitely. We also know that if you have a TBI as an adolescent or just the younger you are, the greater the risk you have of developing a substance use disorder. Go to the next slide. All right, so kind of the summary of this section is that um, some of the consequences of having a traumatic brain injury are going to be, impulsivity, poor judgment, altered reward processing, which is going to increase your vulnerability to substance use. And then you have some of the more psychological and medical complications of having a traumatic brain injury, like chronic fatigue, poor sleep, chronic pain, poor stress tolerance. And so then people will often turn to substances to help them cope. Um, And then on top of that, a lot of our standard therapy kind of assumes that people have reasonably intact cognition. And so if we don't adapt what we're doing to kind of meet our patients where they are, then oftentimes they, uh, fall out of care. Go to the next slide. All right, so screening. You go to the next slide. So there aren't a lot of sort of standard of care guidelines for what to do in the treatment of substance use disorders in patients with traumatic brain injury. There are lots of guidelines for the various substance use disorders. There's lots of guidelines for TBIs, um, but you're not going to find a lot of definitive kind of algorithmic ways to treat patients with both. But SAMHSA does have this advisory that came out a couple years ago, which is helpful. And so it breaks up uh, treatment into these four essential strategies. So the first one is screening for a history of TBI. So we can go to the next slide. So SAMHSA recommends that everyone who has a history of substance use disorder or who is in treatment for a substance use disorder be screened for a traumatic brain injury. There are lots of tools, and so if your institution has a tool that you like, or there's one that you've been using, as long as it's a validated tool, that's fine. Um, they do suggest the Ohio State University TBI identification method. It's just commonly used. It's easy. It's fast. So they say it takes about 5 to 7 minutes. If you go to the website and do the little training, it says it takes about 2 or 3 minutes, which I think is more realistic. So I don't know if anyone's ever done it before, but um, I don't know if you all have access to the slides, but that link should be live. Otherwise, you can just Google it if you want to take a look at it. And then there's also the brain check survey, which is recommended, which is for adolescents and then younger people up to age 21. I don't really see anybody that age, so I've never used that. It is longer. It's meant to be filled out by a parent or a guardian, so it does take a little bit more time. But if we go to the next slide, I have just the first page of the Ohio State University TBI identification method. And so as you can see here, I mean, this is basically the whole thing. Um, and so step one is it's kind of a standardized interview, and so you just are asking people if they've had any mechanism that could be a TBI. Step two is, have they ever lost consciousness? And if so, getting a little bit more information. And step three is, has this happened multiple times? That's really all the information that you need. And then the second page has a bit of the interpretation and what to do with it. Um, but it's very fast, it's very easy. So it really shouldn't slow our workflow down much to incorporate this if we're not already. All right, let me go to the next slide. And then the other consideration would be um, perhaps you have an individual who you have a sense of there's some kind of cognitive processing problem. You do your TBI screening, it's negative. Well, there are lots of other reasons why people might have brain injuries with substance use disorders. So again, they could have a hypoxic anoxic brain injury from drug overdose. So if they're using benzodiazepines or opioids and they've ever overdosed, then that could be the cause. Alcohol again is directly neurotoxic. So there are many other causes of brain injuries in patients with substance use disorders. So we make sure that we're thinking about those as well. All right, go to the next slide. And then the question is, well, what do we do with this information? And so, of course, we'll modify our treatment a little bit. But if somebody is more than a month out from a TBI and they're having persistent symptoms, then essentially, in an ideal world, everybody would be referred to neuropsychology. I don't know if we have anybody on the call who is a neuropsychologist or who does any of these kind of evaluations. I do know that it's kind of challenging in Boise to get in a timely manner for this kind of evaluation. We just don't have enough providers. But it's worth making the referral if possible. Again, if it's been less than a month since the injury, typically you would wait because if somebody had a mild TBI, most of the time the symptoms do resolve within a month. However, if they had a more moderate or severe mechanism of injury, if they have pretty persistent deficits, or there's just something else you're concerned about, it's not wrong to make the referral earlier. That can be quite helpful for kind of getting a sense of, what cognitive domains are impacted for treatment planning. All right, go to the next slide. All right, so now we'll get into treatment a little bit. So next slide. All right, so now that we have screened and identified a TBI, the next step is to make accommodations for treatment. So next slide, please. Um, so It's interesting being a physician giving a talk to, behavioral health clinicians because I can't I don't know exactly what you all do, and so I don't want to presume to ever insinuate that I'm telling you all how to do your job because I don't know how to do your job. But what I will say is that the evidence says that there's really no evidence that says that a particular modality, a particular evidence-based modality for substance use disorder treatment is better with patients who have a TBI. Now, there also isn't evidence that a particular modality is worse with patients that have a TBI. And so the consensus is that, any evidence-based therapy for substance use disorder is still worthwhile in patients that have a TBI. We just want to make sure that we are, adjusting the method to, meet the patient where they are and take into account their cognitive deficits. Because if we don't, what can happen is we might make a misattribution of what's going on, and a patient may be lost to follow up, or they may be chronically late to their appointments, or they may be, they might talk over people in groups or have other kind of disruptive behavior. And, if we're not thinking about the TBI, we might think, oh, this person has low motivation or something else. When in fact, it's really, their cognitive deficits from their TBI. And so if we can kind of modify our treatment, then we could, they're going to be more successful. So we can go to the next slide. And so yeah, so there's this mismatch between standard care models and then what patients that have TBIs often need. And so typically, the standard care models require quite a bit of complex, information processing, abstract reasoning, retention, and people have to be able to cope with a lot of stress and oftentimes work in social situations, or they're in group therapy. And these are all things that can be challenging for people that are having cognitive deficits. So we go to the next slide. So, so what can we do? Well, we can be aware of the cognitive load that we are, basically, asking our patient to undertake. And so how much learning is required? Are they having to, learn a lot of facts, rules, routines? How quickly are we going over the material? And so, can we slow the pace down if we need to? Can we keep the sessions a little bit shorter? What can we do to work with attention and memory deficits? Are we giving written materials and not just oral materials? Are we, helping people to put reminders into their phones so they don't forget to come to the appointment? Are we making sure that the environment is conducive to their treatment? So again, if you have somebody who has a history of TBI and they seem to be getting very frustrated and annoyed or talking over people in groups, well, maybe the group's not the best setting, or maybe they need a smaller group. So just trying to meet the patient where they are. Go to the next slide. All right, so then the next step is the holistic management of comorbid conditions. So you can go ahead and go to the next slide. So, of course, patients with TBI can have the whole range of, medical issues, but the things that are typically problematic are going to be the, cognitive impairment, comorbid psychiatric disorders, and then pain and sleep problems. Um, and so we know that anxiety, depression, PTSD, and suicidality, they're all increased in patients that have had a TBI. And then chronic pain is very common and disruptive, and then chronic insomnia is very disruptive for this patient population. And then it's very hard to engage in treatment when you're chronically fatigued. So we go to the next slide. So what can we do about that? Well, anybody that's having persistent deficits should be considered for cognitive rehabilitation. Again, that's very resource intensive, and not everyone's going to have access to it in a timely manner, unfortunately. Um, and we'll talk a bit more about that in the next slide. But everybody should, be screened for any other co-occurring psychiatric disorders, which I'm sure, all of you are doing that. And then for chronic pain, um, again, we want to try to shy away from, opioids, and which is true for everybody. So this is in no way unique to patients with TBI or substance use disorders, but focus on things like, mindful-based therapies, acceptance and commitment, you know, non-medication procedural care if we need to. And then for sleep disorders, it's really the same recommendation as for everybody, which is that CBTI is the way to go. And then use medications judiciously if you have to, but try to avoid benzodiazepines. All right, next slide. So with cognitive rehabilitation, there's a lot that we could say about cognitive rehabilitation, but in essence, you can think of it as having um, two arms, and so the one arm are compensatory mechanisms. And so that's going to be helping patients to kind of work with their deficits. And so that might be things like, again, using a smartphone calendar and alarm, carrying a notepad around with you, learning other kind of like memory aid tricks to remember things. And then there are restorative based practices, which are going to be things like focusing on actually improving processing speed, attention, memory, which is beneficial. Oftentimes that's, it takes longer and the benefit is uh, smaller, at least in the short term. Um, but and then there's also these kind of metacognitive, practices where people can become more self-aware and try to be more aware of, how they are presenting in the world. Um, Again, we won't go into any more of that. Again, this is a little outside of my anyhow, but that's the gist of it. So you want to go to the next slide? All right, and then development of formal and informal support during and after treatment. So next slide. So, as we would expect, patients that have these kind of cognitive deficits, often having an insight in treatment isn't sufficient to change behavior. And so typically patients with TBI need to have a bit more support. And so that could be, external supports. So things like that are like formal, like in treatment. It could be social support, so having supportive family, friends, peer support, engagement, meaningful activities. It could be more of like, physical supports, having stable housing, having a quiet space in your housing, having, work that accommodates your needs. But focusing on this sooner than later is important because typically this patient population is going to take more time to make progress, and they're going to need more support during that whole process, and then to keep them successful. Because again, the brain injury is not always going to go away, and so they're going to have this structure in place to stay successful. Okay, we can go to the next slide. Now, I'll just talk very briefly about medications and uh, neuromodulation. So just like with therapy, there's really not great evidence to, say that certain medications do or don't work better in this patient population. There's a little bit of evidence in alcohol use disorder. They've looked at valproic acid and topiramate, but they're very, very small studies. And so I don't think we can draw any conclusions one way or the other. And so the consensus is that, we should use the same pharmacotherapy in this patient population that we would use in any other, patient population. Now, if we go to the next slide, one caveat would be that we often will use topiramate, even though it's off-label. It has good evidence, and it's a first-line medication in the VA/DoD guidelines for alcohol use disorder. But as we know, topiramate can cause some brain fog and cognitive slowing. Now, typically with alcohol use disorder alone, um, the benefit of cutting back on alcohol consumption outweighs the cognitive slowing from the topiramate. However, in patients that have, another cognitive deficit, that may not be the case. Now, we don't have enough evidence to say for sure, but I think that it would be maybe be wise to try other medications first. We don't want to give them other cognitive issues. And then there really is no specific evidence otherwise in other substance use disorders. If we go to the next slide. Now, people have also investigated a little bit repurposing substance use disorder medications for TBI. And there's a little preliminary evidence that naltrexone may help some TBI related symptoms. So there's two published reports. It's really too early to recommend doing this, but it's just uh, it's a curiosity. And so we'll see how that develops. And then next slide. And then neuromodulation. This is another one that is not ready for prime time, but neuromodulation, so transcranial magnetic stimulation, it has a number of indications now. So I listed there, depression, migraine, OCD, recently smoking cessation, and then anxious depression. And there's some preliminary evidence saying that this may help with some cognitive deficits around TBI. But again, it's more of a curiosity at this point. The safety consideration would be these patients would have a lower seizure threshold, and so there is a little bit of a concern that that neuromodulation could uh, cause a seizure. All right, next slide. Okay, so those are the key points. So TBI and substance use disorders, they co-occur commonly. They are under-recognized. It's recommended that we screen all of our patients, and if we uh, accommodate them, then they do well in treatment. But if we don't, they tend to drop out. And I think I'm just on time. All right, and then the first talk is gonna be much longer, so I have a lot of references and things that if you're curious about, you can dig through. There's a lot of good stuff.
Thank you, Derek. That's great. We have got just a couple minutes here for questions. So I'm gonna just have one of my panelists kick it off, and then if we get any questions in the chat or from our audience members, we can go to that.
Oh,
Chloe, can
do you mind I'm just curious if
yeah,
anybody on the call does any kind of neuropsych work. Do we have anybody who does that work here?
I think Cam is our only psychologist on the call today. I don't know if you do any, Cam.
I just selfishly want to know who I can refer to if I need to. Hmm. Okay, go ahead.
Okay, Chloe, can I pick on you for any questions or comments first, and we'll see if we have anything from anybody else?
Yeah, I just think one of the comments that I appreciated was the importance of screening because there's so many things that go on with our SUD clients that we like to attribute to lack of motivation or lack of engagement, but it could be because of TBI or it could be because of trauma, and just making sure we're assessing all clients ahead of time so that we can minimize that bias that we have as clinicians.
Yeah,
Yeah, great presentation.
thank you. Yeah, no, I agree, and I think this is one of the paradoxes of the kind of work that we do is that the very nature of a substance use disorder is that we're saying that somebody has kind of lost control over their behavior. And then at the same time, because we're also human beings, we will get frustrated when people lose control of their behavior. So this is just another way for us to remember that, okay, it's no one's fault, so to speak.
Derek, thank you so much for coming back and giving this presentation. I'm really glad that we got to have you present this year. Just so you guys know, I know Derek alluded to this earlier, but the slides are on our overview page. I think Eric already put a link into the chat with those slides. But Eric, if you want to drop that link again really quick for the slides, so that you guys can access those links that are embedded in the presentation. So Derek, thanks so much. And thanks for coming and doing this while you were sick too. So we appreciate you.
My pleasure.